Hi, welcome back to Psychology 2. This chapter, we're looking at psychological disorders, and we're going to do this in two parts. The first part is this week, and next week is part 2. Now, this chapter outlines several categories of mental health disorders and explains the symptoms used to diagnose particular disorders. For each type of disorder, we're going to consider the possible reasons why a person behaves in a particular way with that psychological disorder. Although the research presented may seem overwhelming at times because there's a lot to this, keep in mind that these explanations are closely tied to topics in which you are already familiar. For example, many of the symptoms of mental health disorders are physical in nature, involving brain functioning, neurotransmitters, hormones, and genetics. Biological factors that were introduced, if you remember, in Chapter 2. Many symptoms also relate to psychological concepts such as cognition, thinking, which was Chapter 7, learning and emotions, which were from Psychology 1 in the fall. Now remember, this topic of psychological disorders is a separate branch of psychology. It's known as abnormal psychology, and it's a very big branch. It's also important to note, and this is an important one, please do not diagnose yourself or anybody else. We are not skilled or practiced enough in the field with the use of the DSM-5, which is the diagnostic tool. Therefore, this chapter is an overview of psychological disorders. Now, if you find this a particularly interesting topic, consider taking abnormal psychology as a gen ed in the fall semester. All right, let's get started with psychological disorders. So first, we should, define what is a psychological disorder. Psychological disorders, behaviors or mental processes that are connected with various kinds of distress or disability. However, this is not a personal decision. Rather, it's gauged against some criteria or standard by which to be judged to warrant further investigation. Now, you'll see these in page 307/308 for more information. But let's look at just quickly, what are the conditions by which we are judged to have abnormal behavior? Well, the first is the behavior seen? Is that behavior exhibiting, is it unusual within one's own culture? Secondly, they suggest that faulty perception or faulty interpretation of reality might be at play. This can include hearing voices, seeing things, also known as hallucinations, and ideas of persecution. The third, the person's emotional response seems to be inappropriate for the situation. It's kind of like laughing at a funeral. Not quite the right place to laugh. 4, a person's behavior is dysfunctional and causes some distress to the person or to the people around them. 5, are the behaviors dangerous? Are they dangerous to themselves or are they dangerous to others? And then 6, do the individual's behaviors, are they socially unacceptable? Now, it's a broad range, and a lot of it's on a sliding scale. But that's one of the grouping of criteria of determining whether something is considered abnormal or not. Now, classifying psychological disorders, well, the most widely used classification scheme for psychological disorders is, as I mentioned, the DSM-5, or the Diagnostic and Statistical Manual, that's the DSM, of the American Psychiatric Association. Now, the current edition of the DSM is the DSM-5, and that was released in 2013. Now, one of the major changes in the 5th edition was transitioning for the categorizing system to more of a dimensional system of classification of disorders. For example, changing seasonal affective disorder to the broad category of major depressive disorder with a seasonal pattern, changing the diagnosis of autistic disorder to reclassify it as autism spectrum disorder. Now, there are concerns with the DSM, and let's look at them. Now, when we look at any testing system, and we touched on this in the very first chapter on research, is everything needs to be reliable. So the DSM, whether it was 1, 2, 3, or 4, or 5, has to fit into reliability. Do the different interviewers do they make the same diagnosis when they evaluate the same people? If you can't do that, then it's not reliable. Validity, this is more about the diagnosis in the manual, the DSM-5, correspond to the clusters of behavior seen in the real world. And then the predictive validity is the diagnosis that if the diagnosis is valid, then we should be able to predict what will happen to the person over time. And that can certainly be extremely helpful. So what's the prevalence of psychological disorders within any given population? Well, about half of us will meet some criteria from the DSM-5 about a disorder at some point in our lives. Now, please don't get to the notion, well, I'm going to have schizophrenia at some point, or I'm going to have bipolar at some point. No, when we think of the DSM-5 and the disorders that are listed there, they're not categorized. Remember, they're on dimensions, which means they're on a sliding scale. So even with something like depression, there's low degree and very high degree, and we can be in very distant groups, and it depends on what's happening in our lives as to whether or not that we could fit into that or not. Another concern is that slightly more than 1/4 of the given population experience a disorder in any given year. And so it doesn't mean that everything is prolonged and elongated for everybody. Therefore, not everybody has a diagnosis. Some will self-diagnose and feel like it's happening, but because it doesn't happen for quite as long a period of time, it doesn't fit within the DSM-5. So what we're going to do for a bulk of this chapter is we're going to review some psychological disorders. Now, that's just a review of very big topics. And the first group we're going to look at are what are called neurodevelopmental disorders. Now, that's a group. These disorders are recognized in childhood and have lifelong implications for cognitive, social, and emotional abilities of the individual. Now, the first one we'll look at is autism spectrum disorder. Now, just briefly, when a child demonstrates, first, an impaired social interaction and communication. This could include not making eye contact, not engaging with either peers of their own age or with their own family, and not being aware of the social interaction, and certainly not communicating. The second would be restrictive and repetitive behaviors. So when those two things occur, there could be a diagnosis of autism spectrum disorder. The second one is attention deficit hyperactivity disorder, or ADHD. And this involves 3 symptoms. And now this breaks down into more than just ADHD. And I was diagnosed when I was 42 with ADD, attention deficit disorder. So the 3 symptoms that most would be looking for would be A, inattention, B, hyperactivity, and 3, impulsivity, or combinations on a sliding scale of how much. Now, some of the explanations for neurodevelopmental disorders, well, the causes can be varied, and they're not even very clear across different disciplines. The causes for autism spectrum disorder are unknown. Although there are some markers that are identifying, include older parents can contribute, complications during pregnancy, birth injury, low birth weight, feeding difficulties, umbilical cord complications. It's not clear the cause. The causes for ADHD are also unknown, but they're suspected to have a genetic link and some environmental markers. links between mothers smoking while pregnant and later development of ADHD. Now, the big topic we're going to sort of broadly look at, but it's a big one, is we're going to look at schizophrenia. Now, schizophrenia is a severe psychological disorder that touches every aspect of a person's life. Now, within the diagnosis of schizophrenia, there are both positive and negative symptoms. Let's review positive symptoms. These include excessive and bizarre symptoms, including hallucinations, delusions, looseness of association. Now, the negative symptoms, these include deficiencies, including a lack of emotional expression, a lack of motivation, loss of pleasure in activities, social withdrawal, and poverty of speech. Now, if we're going to try to sort of explain schizophrenia, well, we can look at various perspectives as to what might be the explanation for schizophrenia. And we'll start with the biological perspective. Schizophrenia appears to be a brain disorder. There is less gray matter. There are larger sizes of the ventricles in the brain, smaller prefrontal regions of the cortex, and lower activity levels in the brain, and a loss of synapses in the region. Now, those are not conclusive. Those are just correlational observations that people with schizophrenia also seem to have these things a part of their makeup, which may be an explanation, but it's not the only explanation, because we can also, within the same area of biology, look at heredity. Children with two schizophrenic parents have about a 35 to 40% chance of being diagnosed themselves. Twin studies found that 45% matching the rate for identical twins, 17 among fraternal. So other contributors to this will be, well, complications during pregnancy and in birth, poor maternal nutrition, and maternal diabetes can be contributing factors. Alcohol abuse by the mother may impact brain structures and increase dopamine and increase the number of dopamine receptors. Now, moving away from biological, we can move into the psychological perspective to understand where maybe the influence on schizophrenia is. Learning theorists explain schizophrenia in terms of conditioning and the social setting. Socially unrewarding or punitive situations in their home environment, inner fantasies become more reinforcing than the social reality. Hospital staff pay more attention to parents who behave bizarrely. Family discourse and stress may contribute as well. The sociocultural perspective. Social and cultural factors such as poverty, discrimination, overcrowding can contribute to schizophrenia. Especially true among people with a genetic predisposition. Now, the rates were twice as high among those in the low income, social income level, and poor quality housing. So there's a correlation, not a cause. Now, critics do point out an issue here. Are schizophrenic patients influenced by these issues, or is it because they have schizophrenia that they experience these situations? And it's a good point. Now, the next grouping we'll look at, not in terms of another explanation for schizophrenia, is the biopsychosocial perspective. Now, people with a genetic vulnerability to the disorder experience an increased risk when they encounter problems such as viral infections, birth complications, stress, and poor parenting. The next psychological disorder we'll explore is depression and bipolar disorder. Just by virtue of grouping them together, they fall within a group, but we're going to look at what makes them similar and also what makes them different. Now, these disorders are characterized by disturbances in expressing emotions, generally involving sadness and elation, so the highs and the lows. We'll begin with major depressive disorder, or MDD. MDD is classified as a serious to severe depressive disorder in which the person may show a loss of appetite, psychomotor retardation, just means psychomotor slowing down, the rate in which you think and move slows down, and impaired reality testing. So some of the characteristics include a lack of energy, a loss of self-esteem, difficulty concentrating, and a loss of interest in activities that you once found enjoyable and other people, pessimism, crying, thoughts of suicide. MDD affects about 5.3% of men and about 9% of women within a given year. That could mean that people come into depression and go out of depression and never experience it again. For others, they come into depression, they go out of depression, and then repeat. About half who have major depressive disorder also experience poor appetite, serious weight loss, agitation, which can be a part of that psychomotor retardation. They may experience, they can include delusions of unworthiness or guilt for imagined wrongs, or devil administering punishment. It gets pretty in a very dark spot for some people in extreme examples. Now, bipolar disorder, it was formerly known as manic depressive disorder, and it's characterized by mood swings, moving from an ecstatic elated to deep depression. In the manic phase, a person may show excessive excitement, silliness, poor judgment, and may destroy property and give away expensive possessions, too restless to sit still or sleep restfully, and they experience rapid flight of thoughts and can be very argumentative. Depression, this often includes sleeping more and unusual and being lethargic. Individuals also tend to withdraw and experience irritability. So if we're trying to explain mood disorders and we take a biological perspective, well, depression is inheritable. It's associated with the trait of neuroticism, and we talked about that in a previous, in personality theory, when we looked at that in the chapter. Genetic factors appear to be involved. When we do twin studies, it suggests the powerful role of genetics for bipolar disorder. The psychological perspective, well, learning theorists suggest that depressed people behave as though they cannot obtain reinforcement. They have an external locus of control. They think that they can't control the world outside, that the world outside controls them. They do not believe that they control the events to obtain reinforcement. Researchers have found links between depression and learned helplessness. Seligman's study, where dogs were taught that they were helpless to escape an electrical shock. Now, when you could escape, they didn't. They had learned they couldn't control the environment that they were in. When I was in university, I did an experiment with a small group of people where we were teaching university students to be helpless. And we created a light board. And in that light board, we could control how successful or how poorly you did. And in doing so, we could increase the likelihood that you would fail simple tests when we gave you a puzzle, a 100-piece children's puzzle turned upside down so you couldn't see the image, that those students that had no effect on them by the light board that we created, and therefore they had high success rates, went to the puzzle and could do the puzzles just fine. Those students that we controlled their success and had them be less successful, while at the same time seeing the successful results of their peers, ended up when they moved to the puzzle paces, they couldn't complete it in the time allotted. And so this whole notion of learned helplessness is a very real thing. So this helplessness resembles behavior of depressed people. Now, the cognitive factors that might be involved, they contribute to depression, includes making irrational demands on themselves. Depressed people tend to ruminate about feelings of depression, and thus rumination prolongs the feeling. Rumination is about just thinking about it over and over and over again. That can continue those same feelings over and over again. Now, within this same grouping, we can look at the attribution styles, which include the internal versus external, stable versus unstable, and global versus specific. The attribution, we got that from personality as well. People who are depressed tend to think of their own situations, of why they feel badly is because of what they contribute. It's internal, it's stable, it doesn't change, and it's global, it affects everything. They are powerless to change it. The biopsychosocial perspective, well, with some biological predispositions, attitudes and situations can play a role. Reactions to stress, such as chronic strain from, marital discord, financial problems, and things like that. People who are depressed have lower self-esteem and are less likely to solve social problems and have less social support. Depression, hopelessness, and helplessness can certainly affect a person's diagnosis with depression. Could lead to suicide, and suicide is very difficult to understand. We're going to look at some of the content. Let's look at some content in your text regarding suicide. I know it's a difficult topic. About 3,700 people each year take their own lives in Canada. About 3.7% of the Canadian population considers suicide. It is the second leading cause of death among Canadian adolescents. Now, what are the risk factors? There could be very many, and they're very personal and specific, but we can generalize some through research. Some of the risk factors are linked to feelings of depression and hopelessness. Rigid perfectionists, that is to say that I have a very high expectation to achieve, irregardless of whether it's reasonable. Another, setting impossibly high expectations for themselves can put them in a position of not being able to see how they can succeed. They may even be comparing themselves negatively to others. I love basketball and I play a little basketball, but if I compare my basketball game against those in the NBA, I make an unreasonable comparison, and sometimes that's what happens. Suicidal adolescents experience 4 psychological problems. They have confusion about themselves sometimes, an impulsivity, emotional instability, and interpersonal problems. Some sociocultural factors regarding suicide. Well, suicide is the second leading cause of death among young people in Canada, as I mentioned. So culturally, that plays a role. What is going on with young people in Canada when that's the case? Suicide is more common among college students than among people of the same age who do not attend college. So it certainly speaks to the role of stress, achievement, meeting expectations, your own. Older people are more likely to commit suicide. For the Aboriginal or Indigenous peoples of Canada, suicide rate is just about 3 times as high as that of the Canadian general population. Men who immigrate to Canada are at a reduced risk of suicide. The average suicide rate for Canadian men of all ages was about 21.6 per 100,000 people. Whereas for men who immigrated to Canada, the average suicide rate was significantly lower at 12.9 per 100,000. The suicide rate for immigrant women, 4.9, is not statistically different when compared to rates of Canadian-born women at 5.3. 3 times as many women as male make attempts. 4 times as many males succeed, often because they take more. They often will use techniques that are more likely to be successful. Some myths about suicide. Well, one myth is that most people who commit suicide give warnings about their intentions they're just not, they're just seeking attention. Well, that's not the case. Many people who commit suicide they have made many attempts prior. Well, and that's not necessarily the case. Discussing suicide with a person does not prompt the person to attempt suicide. And suicidal thinking is not necessarily a sign of psychosis, neurosis, or personality disorder. Now, I know that was a tough place to end it, but that finishes part 1 on psychological disorders. Now, in part 2, we're going to explore anxiety disorders, obsessive-compulsive disorders, somatoform disorders, dissociative disorders, and personality disorders. Now, that sounds like it's a big chunk, and it kind of is, but you'll get some idea about what is involved in this. So I hope this has been helpful, and we'll look forward to seeing you next week in the part 2. Bye now.